the North West London Acute Provider Collaborative Board in Common. Thank you for those of you who've given up your time to join us today, and apologise just for being a couple of minutes late. We will be taking questions at the end of the meeting. Then I would ask members of the public their microphones on mute so that we can hear their Amazon deliveries and others. I would like to apologise for the insanity of the camera, which for those of you watching may get seasick. It is a highly developed piece of technology which focuses on the speaker sometimes, and sometimes it gives you an out of focus picture of the ceiling. But you may choose which of those you prefer. And to say that this meeting is being recorded, and the video of it will be made available later, but by joining us, you are giving us permission to record whatever words or images you share through Teams. So I've got a few just welcomes and farewells. I'd just like to first of all, I've got apologies from David Moss, Lloyd Lobo, and Rob Bleasdale, who's currently sitting in the dark in Spain trying to get back to England. And also like to welcome Catherine Williamson, who is our new academic NED representing from Imperial College and sitting on the board of Imperial and Chelsea and Westminster, so the twin to Martin Lutton. That's so well in the other two trusts. So we've also got a bit of a shuffling of personnel, which you will have seen in the Chief Executive's report and in my own report, but to welcome Alan McGlennon, who you know as the Chief Medical Officer for Hillingdon Hospital, has also taken on the role of Managing Director for the Trust. Virginia, who has taken on the CFO role across both Chelsea and Westminster and Hillingdon, and Jason, who has taken on the role of Chief Infrastructure and Development Officer across Hillingdon and Chelsea and Westminster, and Kevin, who has he is in the room with us. Hi there, Kevin, who's taken on the role of Chief People Officer now across Imperial, Chelsea and Westminster, and Hillingdon. I would also just like to say that Janet and Huda are standing down, I think, at the end of this meeting as our associate NED. So my thanks to everything they've been doing for us. And this is Claire Hook's last meeting as Deputy Chief Executive and Chief Operating Officer at Imperial. And she is going off to be Chief Operating Officer at the Crick Institute, one of the world's leading research centres. So our loss is their gain. Thank you, Claire. So let us move on now to, if I've missed anybody, feel free to throw in anybody I've missed. That's a long list from my point. So let's move on to declarations of interest. And Peter, you are going to give us an update.
Yes. Excuse me. So this is the annual presentation of the Register of Interest. As you know, we update this as we go through the year. We'll take any updates to the declarations of interest at each of the meetings, and any interest on any of the agenda items that we are discussing at that meeting. But once a year we present this in the public, so we've got a record of our Register of Interests. I won't go through it in detail, but it should hopefully reflect all the current interests that have been declared.
Thank you. Yeah, please.
Just as directors at London North West, we are automatically trustees of the charity, so we don't tend to declare that, and none of us have declared it on here. So I've noticed it last night. So I don't know if we need to put a notation in around that. Just to.
Yes, let's make that annotation. I'm not sure it's the most threatening interest that we should worry about with that. But yes, thank you for that. Okay, in which case I would ask the board to note the register and the amendments, and it will be published on the collaborative website. Thank you for that, Peter. Okay, so moving on to the minutes of the previous meeting. Are there any corrections that people feel the urge to make? We will accept those minutes into record, and then on the actions, I think we have a number of updates. The IQPR performance report that we said we would be we're suggesting that we would have a new version of it. That work is in progress at the moment, and I'm expecting for us to have a new look and feel for that, reflecting the new structure of our contracts for the next meeting. We've got the non-clinical pathways. We were asked for an update. I think that is on the agenda. I think EDI we're picking up on the agenda. Safeguarding, we are waiting for the ICB. Any other actions that people want to raise? In which case, I am very pleased to move us on to the staff story, which I think Pippa is going to introduce our Brent Back to Health programme. So Pippa, can I throw it across to you?
Yeah, thank you. So you're going to see a video. It's an example of a programme that's running in all of our trusts, which is where we are volunteers are phoning patients to help remind them to encourage them to come to their appointments. We have particularly targeted patients from our vulnerable deprived areas because we're trying to break down barriers to health. So it gives you two things. It gives you a bit of an anchor institution story, because volunteers that are making these phone calls are very much local, younger people that are trying to access careers in healthcare, and that's given them work experience to be able to do it. Gives you an example of actually they can speak to them in their first languages. They also live in the local population, so they really understand some of the challenges. It will lead on. It's a bit of a lead on to the EDI work that we've been doing around patient equity. Thank you to Piers and Martin, who made the video and did the filming with the volunteers, because they've done a great job of capturing a very long interview and a video at the start. They've done a great job of capsulating that.
So let's play the video.
My name is Fumi, and I'm the volunteering coordinator at Brent Carer Centre. Brent Carer Centre is a registered charity that has the sole contract from the London Borough of Brent to support all the unpaid carers within the borough. With the Brent Back to Health project, our volunteers, our lovely volunteers, call up the patients to remind them of their upcoming appointments, to reduce the number of DNAs in the NHS. Currently, we're working with Northwick Park Hospital, Central Middlesex Hospital, and Ealing Hospital. We call them 2 weeks before their appointments, and that gives the hospital ample time to allocate those slots to other patients and to reorganize another appointment for the patients that could not attend.
Hello, my name is Alexa Gonzalez, and my job role is volunteering in Brent Carer Centre. I've been working in Brent Carer Centre since January. I make calls for patients, like to remind about the appointment. But what I do to call them up is to say, I'm calling you to remind that you have an upcoming appointment at this date, at this time, at this department, and if they will able to attend. I can make up to 50 calls a day.
For ophthalmology, we have around 190 patients we call a week. For cardiology, endocrinology, around 30 patients per week, and maxillofacial, around 80 patients per week. Those numbers are growing. They generally feel really happy to hear, number one, that the hospital cares. I find that's a reaction that the volunteers have a lot. They actually say, thank you that you cared enough to call.
Me as a Brent resident talks to another Brent residents, I may understand where they come through. For example, the transportations, like every hospital is far away from them. The positive that happened to me during the phone call is when patients like be happy when remind them like, oh, thank you for remind the appointment. Like I didn't know, and I will put it this time on my calendar. Or can you please send a text message or a letter? And that made me feel happy, so I can put it down on the sheet and pass information to the hospital to able to help them as well.
I find that taking children to school, the school time, is a challenge for parents. I find the fact that lots of people that we call, lots of the patients are working. So getting time off from work is a challenge. There was one particular scenario which I remember where the person was on the spectrum and they specifically said that they weren't in a good place right now. So because of how they were feeling, they couldn't attend. And I flagged that up because I felt that person needed some extra help. Sometimes we have some patients that don't speak English, so we call on them. Our volunteers feel comfortable enough to call on them, and they come on the call and they help the call to go through. The value that I see more is the value of the volunteers that are involved. They really enjoy working on the project.
Skills I learned from Brain Care Center is like communication skills as well, verbal, non-verbal, and also like the IT skill like data entry. As a part of the health and social care course, helped me to like gain more knowledge to apply for work placement as well. I can apply it on my placement, and also my placement will help me as well as an individual and as a student to develop the skills that I learned. When I finish college, I want to do university as children nursing.
I think lots of people have, unfortunately, not a very good experience. Some of them don't have a good experience and think that the NHS doesn't care and so on. So I think when they see that the NHS is collaborating with local communities, it makes them think, oh, they're actually trying to improve the services and they're actually willing to listen. And I think that can't be bad. That's quite good.
Good. Thank you. Did you want to add anything to that?
Just to say that's a preamble to some work that will be up later when we complete the items. That sets the scene.
Excellent. Any questions or comments from? Yeah, please.
Yeah, I mean, I think this is excellent. I think it's really a good, good service to provide. I think particularly good for volunteers, people who are volunteering, and get them into transition to work, etc. And I think it maybe doesn't take away from the fact that we need to be dealing with structural discrimination, racism, unfair practices, etc. But and also sort of those with linguistic and cultural challenges. We need to, as a system, we need to be dealing with that anyway. And I know we are. But I do think this is excellent. And the other thing that made me think about was people from BAME communities and the chronic illnesses that are prevalent in those communities, diabetes, cardiovascular, hypertension, etc., and which may require regular follow-ups. And just wondered whether there's something around that, and also about where we measure the impact of this particular service, and so making sure that the learning is embedded and actually does help the challenges around discrimination, etc.
Thank you.
Yeah, so you'll see with the presentation that we come on to, we've got some evaluation of the work, so you can see how much it's reduced or helped with attendance. But I think you're right. This is the other thing that they talk about is patients that have numerous appointments. So take a sickle cell patient that has numerous parts of their body that need to be seen by different clinical teams. They'll choose which appointment to come to because they can't afford to come to all of them, or they can't take time off work to come to all of them. So it's how we can design our services so they can literally see everybody in one go. That's what they're saying to us. But some of this, when you're talking about hypertension, this is where our neighbourhood teams need to come in. This is where we need to stop bringing patients to hospital that don't need to come to hospital, and healthcare can be provided in their local communities. So this is the 10-year NHS plan, isn't it? And that's how we're going to have to redesign our health services now. And that's absolutely right, that we should be providing them services locally in a local community to be able to provide the healthcare needed for that unique population.
Thank you. Said.
Thank you. I just was very intrigued about the people in the spectrum that the lady described. And I think such a good discovery, an important one. Perhaps we are already catering for that, but are there, if we are mindful of that, what are we doing to help people with mental health conditions who may feel good one day and may not feel good the other day, to help them negotiate the outpatient appointments, etc.? Thank you.
Thank you.
Thanks, Syed. So the patient she was referring to was actually a patient that has ADHD and finds it quite stressful coming to a busy waiting room, finds the whole experience a bit difficult. We've all got accessibility programs, and what we all try and do is first of all identify these patients, and our systems allow us to do that. And then what you do is try and accommodate them at the start of a clinic or the end of a clinic. So you'll try and get them in first so they're not waiting long, or you'll try and bring them at the end when the waiting room's not very busy. Now, I'm not saying we always get that right. The key thing is identifying these people first of all. So understanding their neurodiversity is really important. And then disclosing that to us is really important. So we can then try and adapt clinic appointments and things to suit their needs.
Thank you. Anna.
Yeah, I think the work that's being carried out is really excellent. And I was wondering what scope there is to extend it across the ABC, because clearly it is showing results. I don't know if there is to extend it.
Yeah, so we've already got it across the APC. We've got it in different models, and you'll see some of that in the work that we're going to present after shortly after this. And I think that's fine. We don't have to be prescriptive about how we've done it. The key thing is, how do we continue to fund it? And actually, this made me realise how important the funding is for it. This is a double win. This isn't just about patients accessing our service. It's actually about how the anchor institution piece of it and how we're helping local people access healthcare, careers in healthcare. So it really does have a double benefit, actually. And we're just having some conversations with Brent Local Authority at the moment to look at how we can pull this into the anchor institution work we're doing with them to try and look at volunteers into healthcare and how we can potentially access some funding through there as well. So we're all very committed. We will keep this running. We're all doing it through different ways. But I think that's absolutely fine how we're doing it. It works differently in each location.
Thank you. Julia.
Yeah, no, I mean, this is really, really good. And the important thing for me is also about how we can take this forward into the health coaching world, because it is about not just about appointments, but about making sure patients have immunisations where they're needed, making sure that they know how to access social security and to citizens' advice and things like this. So I think there's the more that we could expand on with these roles, but the funding will be important.
Yeah, I agree. The social prescribing bit of it is really important, and that's certainly what we can help them with. How do we then help them have a meaningful conversation around accessing the benefits they're entitled to? A lot of them weren't aware that the benefits they could get to help them come to hospital to attend appointments and the funding support there is from that. So the social prescribing piece is just as important as the actual information that they're given.
Thank you, and good sucking up there, Julian, as I now have to declare my interest as being the chair of Citizens Advice National.
That I didn't know, Chairman. Apologies.
Speaking at an NHS conference in Liverpool about how Citizens Advice is running social prescribing in Liverpool. So that is but that point about benefits and how there's so much more to healthcare than simply what we do in hospitals. I think is what this is a sign of, and I like this because it's beginning to deliver what we will come back to when we talk about our health equity strategy later on. Using data that actually identify where there are inequalities and then being laser focused about the areas where there are inequalities. So it's not we do a little bit everywhere. Here we found an area where there's a real difference in DNA rates. Now, what can we do to go and change that? And it allows us to target our resources to where we think we can. But thank you for that. Thanks for that, Pippa, and pass thanks on to the folks who are actually doing the real work out there. All around the board for the rest of it. Thank you. Okay, I'm going to move us on now to my chair's report, which you have in writing in the pack. So there's just a couple of things that I'd like to draw attention to. The first one is just the opportunity to look back on last year and express my thanks to the leadership team that are around the table and their teams for where we got to by the end of the year. there was an interesting dynamic played out that we were set a target to deliver a 50 million deficit across the collaborative. None of us were happy about that because we were set out to create a break even across the collaborative, and we ended up hitting that 50 million deficit target, which took an awful lot of work by an awful lot of people. So thank you for that. When what's known as the true up was done, how much work have we done for patients? How much extra activity have we done, particularly in our emergency departments, but in various areas? It turned out that we'd done £75 million worth of unfunded work across the collaborative. So in reality, we delivered a slightly more efficient group of hospitals than we set out to do at the beginning of the year. I think that's worth drawing attention to, just because it's a sign of how hard and how well people work, but also it ties to both the point that we make frequently in our quality review, is that this is the safest group of hospitals in the country, and as shown by the hospital mortality data, and that doesn't mean that we don't make mistakes and that we don't have things that we have to fix, or that we are perfect and we are continuing to scrutinise ourselves. But under that sort of financial pressure, we continue to deliver that level of safety, and we delivered the largest growth in elective activity compared to how much work we were doing pre-COVID of any group of hospitals in the country. So all of that is a tremendous achievement. And as we look into the coming year, and we will be discussing our business plan for the coming year at some length, it is worth people bearing in mind that we have signed up to delivering a target of a 4% productivity improvement, which is the national target. We're working through our plans to get that. That's got that. That is a higher level of productivity than the NHS has ever delivered since 1948 in a year. So it's not without challenge. But when we look back to a £50 million deficit and £75 million worth of unfunded activity, this year's plans are based on an assumption that demand will stay flat. So we can do and we must do what we have to do in the hospitals, and that will be very challenging, but it's tied to a whole host of things that need to happen in the wider system and under the ICB to actually ensure that we don't see the growth in emergency demand in the coming year that we saw last year, because if we do, our financial plans will go out, our commitments to delivering performance will go out, and this really does require a system response for us, both doing some really hard stuff in our hospitals and really tough stuff being done in the wider community to provide alternate ways of people receiving the care that they need that doesn't involve them having the function they need. So I think that will be a continuous discussion through the coming. I've done a number of welcomes to people, and I should also note that Tina Benson and Tracy Cottrell have both left Hillingdon. Tracy was the interim finance director, and her period of office came to an end, and her responsibility has been rolled under Virginia, as I mentioned earlier. And Tina has gone off to be the Chief Operating Officer at Frimley Park Hospital. So good luck to her and to them. I'm then going to move us on to just briefly referring to the Cabinet meeting, the Board in Common Cabinet summary, which the papers are also in front of you. It won't surprise you at all to know that we spent most of that meeting talking about the business plan for the coming year, which we're about to rehearse again, and a particular emphasis from the chief executives that this first quarter of the year is going to be very important, that if we're going to deliver this challenging plan, we can't do it by being adrift after the first 3 months. So there's a lot of work to be done. We also had a conversation about the Clinical Pathways programme, which is beginning to make some very interesting inroads on our clinical teams working collectively across the 4 trusts, and how we tilt that into doing the same sort of working together in the non-clinical areas as well, both of which will be a continued priority for the coming year. So I think with that, we ought to move on to the bones of this meeting, which is our financial, operational and workforce business plans for the coming year. And I'm going to throw that across to Leslie to lead us in.
Thank you very much, Chairman. And let me just say, first of all, thank you to everybody, actually, because this has been a concerted effort across all professional functional groups and all organisations. I am going to hand over to Jazz, but before I do, I just want to, particularly given this is a public meeting, and you have nuanced it, Chairman, which is that this is a very challenging year that is ahead of us, and a challenge in as much as we have to land a tricky financial position, and we have to deliver some very particular things. And we have tried very hard in this plan to ensure that the national must-dos around the front door of the emergency departments, are offloading of ambulances, and our meeting of the elective targets are in here. And it will take a concerted group effort to allow us to land the overall plan. What I should also say is, and we cannot and will not be able to do that by doing everything the same way that we have done it previously. So it will mean that we will need to make changes in the way that we provide services. It will mean that we will be speaking and are speaking as to all of our clinicians about how they provide services. And it has meant, and will continue to mean, that there are some concerns by particular groups of staff around the future, because as we will have seen, NHS England, our ICBs, regions have been told to make staff cuts. Indeed, all of our organisations have been asked to have a look at the workforce and the growth in workforce and non-patient, direct patient provision, of cutting that growth of 50% between 1920, 24, 25. So all of those are very challenges, and I want to put it out in the public arena that says we are going to have to think very differently about how we do things, and we will, of course, engage with people as we do that. But nobody should go into this year thinking that things will just remain the same. So thank you for giving me the opportunity to say that. Jazz, I'm going to hand over to you and to do the financial bit, and then we will go through, if that's okay, the operational bit and the workforce. Chairman.
Thank you, Leslie. Yes.
Thank you very much, everybody. So just in terms of a high-level summary, the planning round includes decisions that we all have to make. And they cover finances, they cover operational activity and performance, and they also cover workforce. And obviously quality is embedded within everything that we respond to. In terms of key highlights for 25-26, and some of this has been touched on already, as an APC, we have submitted a break-even income and expenditure plan. That is after receiving 121 million of additional non-recurrent support from North West London ICB. And we have had about £49 million worth of additional income in relation to the process the ICB undertook to true up, to Matthew's point earlier about where performance is higher than funded, and local prices where local prices we felt needed to be reviewed and re-looked at. So both of those have been positive, and they support the position in terms of getting to break even. In terms of the cost bit of the financial plan, there's national guidance around what we should apply to each of our pay and monthly cost uplifts. That's what the plan assumes. We've done nothing more. So if inflationary pressure is higher than that, then that may manifest itself throughout the year. And think about how we mitigate that on top of the additional efficiencies we've got to make. The whole plan is underpinned by £178 million worth of efficiencies across the four organisations, and our focus has been for 25-26 to really look at our cost base, because the opportunities to grow our income are now limited, and we know that the national narrative very much is the money is the money, and we need to think about how we get more productivity and efficiency out from the resources we have deployed. That level of efficiency is about 31% higher than what we actually managed to achieve in 24-25. So we know that that's a challenge, and we need to get on the front foot for that. All the organisations have developed efficiency plans. We're not quite at 100% yet, but then each organisation has also put in measures between now and that position being a reality to try and think about how it curbs its cost base. And most of us have got very control panels in place. We're looking at use of bank and agency and how do we reduce reliance on that so we can try and manage the position every single month going into 25-26. In relation to the other bit of the financial plan, we have to submit a capital plan, and the capital plan for 25-26 is worth about £284 million. That's a significant amount of capital investment we've got to deliver on, and that is partly funded through internal cash generation, but also we've got some national cash-backed public dividend capital that we've managed to secure, which is really helpful in terms of advancing our capital programme, making the right investments where we need to. That £284 million does exclude charitable donations and grant funding. We get substantial money through those routes as well. We're always very grateful for that, and it's always cash backed, which is really, really helpful. In terms of the operational plans, as Leslie said, we did submit on the 27th of April a set of operational plans. We had a check and challenge session back with NHS England, the region, and we were asked to go away and relook at our referral to treatment trajectories, and we've resubmitted those. I'm sure we'll talk about that on behalf of the APC in a minute. As Leslie has said, the plan is not without risk, but I think we all understand what that risk is and the kinds of things we need to think about in terms of delivering financial balance in 25-26. And obviously this board will be briefed on those initiatives as they come through as well. In terms of workforce, the total efficiency asked and the workforce we need to reduce is about 1,260 whole-time equivalents. And that means that we've really got to go after looking at where are we spending money and how do we make sure we can deliver what we need to deliver within the reduced pay bill. Our cash forecast for the year is currently 185 million, and obviously we're tracking cash very regularly to make sure that we do make sure we can pay our providers and our suppliers and our staff in a timely manner and rely as much as we can, not national support wherever possible. But we have had to rely on that in 24-25, and there is money available nationally. We just have to demonstrate we're doing everything we can before that payment will be made, but there's not an issue about accessing support that's required. And I think the main point, or the last point of my summary would be, we're absolutely paying attention to the quality of care we are providing. So the organisation has a quality impact assessment process. So anything to do with efficiencies, anything to do with service change, anything to do with workforce is reviewed as part of that process to make sure we understand the impact, being negative or positive, and try and put into place any mitigations we need to make sure that we don't do anything detrimental in terms of the care we provide. So that's what the plan goes on. The whole plan has been through each organisation's trust standing committee, and it has been approved at the board in common extraordinary meeting before submission was made.
Thank you very much. So,
thank you, and thank you for the paper. I noticed on page 54 on the capital expenditure, around 32 million of it is critical health and safety works across Imperial and Hillingdon. Are we going to see these disaggregated so we know exactly where they are? Because obviously the board needs to keep an eye on something that is quite critical in relation to health and safety.
Individuals will absolutely have that level of detail. But in the individual board papers, that detail's in there. That's helpful.
Because I haven't seen it yet. I'm assuming that for the future it will be there.
I was going to say each finance and performance committee at each organisation should see all the detail for the whole capital plan, especially around health and safety, fire safety type of issues. And then when we report here, we can think about making sure we're explicit about that going forward.
we bring it to the capital committee and for noting there that just to aggregate up what's gone to the individual boards so you get the overall picture. Is that right, Bob?
Maybe this is one for Leslie. Sorry, Leslie, I can't see behind your head.
You have a lot.
Faces it all. Yeah, exactly. So I think Matthew and Leslie both alluded to it, but this plan relies on the delivery from the whole system. In fact, on delivering more prevention than it's ever delivered before. So I think for us as an acute provider collaborative, how are we assured that the progress that the ICB or the ICS is making on that left shift, that prevention in the community, is in step with the plans that we have to deliver, because we need their help. kept, as Pippa said, out of our front door. So in order to deliver this plan, we need to rely on the system to deliver its portion of what we're asking for. So how does that marry, Leslie, and are we assured that that's going to be the case this year?
So I think that's a very good question. So I think that we can articulate pretty well what needs to happen. I think there are efforts in each bit of the system, be it around made into hospital, and then what happens to patients who need to go into community or mental health or local authority care. We can articulate the numbers. I think there is a lot of work going on, but there remains questions. And one of the things that we might do as a board is potentially, Chairman, to ask the ICB to come and do that presentation of, in one of our development sessions about the work that's going on in terms of the neighbourhood work. Now, we're part of all of that, but I think, I can say whatever I like, but I think in terms of providing that assurance, I think that would be probably a helpful thing to do.
Tim.
I'm in a sort of glass half empty mood today, just to warn you. So I think the board needs to note that as a significant risk. So I think that however you cut it, irrespective of what the starting point is, all of the ICBs have been asked to reduce their headcount by a further 50% on top of the 30% that they reduced it by before. So I think that we need to be really clear about articulating what are the key actions that we think will make the biggest difference to making the system work, and work with the ICB to help deliver those. But I think we have to recognise the fact that it is a less than stable situation, and that does then pose a risk to some of these plans.
Thank you. Bob.
So it picks up, it's in the same vein as maybe a bit more specificity. When we did sign the plans off, not only did we have things which we recognised were system assistances, but there were matters pertaining to each of the organisations which were still subject to final contractual agreement with the ICB. The time frame for that was the 8th of May, I think, is the national contractual agreement time frame. It will be quite helpful to get a sense of how well or otherwise those concluding conversations are going, as an assurance to us that agreements might be signed, an acknowledgement we may be having conversations in other places about what do we do if we haven't. Quite helpful, I think.
Okay, I think that's look, we can feel the nervousness of the board on this plan. It is a very challenging and very challenged plan. And I think all of those questions are very fair. It might be worth us just nipping around each of the CFOs in terms of the specifics around where those those outline and outstanding areas are.
I'm going to take Phil from you, and then I'm going to do exactly what Leslie says. And when we go around to CFOs, I'd also just like to pick up where we discussed this at our special board meeting in order to hit the deadlines. All the trusts have promised an improved performance on the one that we signed off as a board, and London North West has signed off quite a lot of extra activity, which appears to not come with any extra income. So it will just be useful to get some assurance on that. But Nick, do you want to do your question?
Because we were told to sharpen our pencils on operational performance, but there's still some red on that graph, and I'd be interested in sort of some explanation of potential consequences, because we haven't got to the national target that we've been given on some of those. So I think it'd be useful to have a look at that, just understand if there's any consequence where we are and whether there can be any further movement.
Yeah. Does each of the chief execs want to talk about this, or can you talk about 2000?
Let me say something overall, which is in the 60% in particular. There's a piece of work that says around the treatment, but there's also a piece of work that you heard me talk about earlier that we're mapping out that says if we were to swap the follow-ups, which is a discussion that's taking place in every organisation, So we are now enforcing the change of templates by specialty along the GERF level templates, which we think will get us there. It's wise that we do need to work as a system, because the expectation is some trusts are going to have to do better to get the overall to where we need it to be. But it's probably better than now if we go round.
Do you want to pick up on?
Yeah, no, I mean, so I think this has made the key point. So I mean, and there's a London-wide drive to try and solve, which Joy I have to chair, on the Learning Improvement Network to try and work out what we can do to optimise first outpatient appointments. So we know that we are all doing a very large number of follow-ups that we are not paid for. So actually, it makes very little difference to us in terms of income when we swap from follow-ups that are not paid for to news that are not paid for. Forget news that are not paid for. Actually, then we can deliver the target. I think, in a more general point, there is a concern, obviously, about not undertaking additional work that we don't get paid for, and some of that is a conversation about what is currently sitting in so-called deficit support and how that transfers into earning. And some of it is around a straightforward discussion about what we think we can deliver with the money we've got. The other thing to say is that as you probably know, there's a validation sprint of the NWL going on for the first 3 months of the year, where everyone is being encouraged to go through their entire waiting list to validate it, with, I'm afraid to say, a financial incentive for every patient removed from the waiting list. I think that will help people hit the number. I think the thing you just need to remember about that is that is hitting the number without a single additional patient being treated.
Thanks, Tim. What noise? Right, so let's just walk around the CFOs just. So I'll do Jazz, then I'll do Virginia, and then I'll come to you.
Yes, I think a couple of points I'll make probably span across all the organisations anyway. So we have been engaging with the ICB to provide us with the underlying data about how they came up with the true up value, so that we could just validate what they've done, what activity numbers they've used, what prices they've applied. So that once and for all, we can understand whether that value is the right value. That's about £49 million that's come into envelopes. Fortunately, we haven't had that level of detail, but we're trying to do our own independent analysis again. That's one thing, the system we're trying to resolve. The other bit is, I suppose, and people have commented already, there is no new money. The envelopes have been it. He has no whether it's going to put into the APC. But to Tim's point, the key thing we're trying to understand is with these contractual items where we're raising concerns either about the pricing, either about the amount of activity we're doing, or concerns we would have, it'll be about moving that money out of unearned support funding into earned. So it becomes part of our recurrent envelope, and we will then provide the work we are providing against that. So just wanted to make sure the board is clear about that. And then each organisation is pulling together its own list of contractual items. So for Imperial, we have a number from each division that we have pulled together, and we will talk to the commissioners about these are the areas that we think you need to come and have a conversation with us. Critical care is one of our biggest ones, and that obviously spans not just the ICB contract, but also specialist commissioning. And with the delegation of budgets, we need to make sure we join that all up properly to make sure that the amount of capacity we have open is fully funded. The allergy service, Tim's mentioned already, we're just trying to find a piece of work and the sustainability of that service financially, what tariffs are now in the envelope versus what was in the envelope, what's our cost base. And then there's a number of others that we are just trying to make sure we also have on the list. So I think we have a process. The ICB is clear it needs to achieve something by the 8th of May. We had a conversation last Friday at CFOs about them telling us explicitly how we're going to do what we need to do to deliver on that. Because at the moment, I don't think anybody's quite clear about the process that they're expecting us to adhere to. So that is work in progress that they should be sending out ASAP, given we are where we are at the end of April. We haven't got many days left.
Thanks, Jess. Virginia.
Yeah, thank you. Not a huge amount to add to what Jazz said, because that applies to all 4 trusts, but the other bit for both Hillingdon and Chelsea and Westminster is around the out of area contracts, so just making sure we finalise all of those. There's no risks to escalate at this point, but they're just not all finalised yet. And specialist commissioning is the other one. And just to note, So I don't think we've probably talked about it here that specialist commissioning majority of services are being delegated to ICBs from this financial year, and this year is a transition year. So that's just being worked through. It should be the budgets that are being transferred are in line with expectations, so it shouldn't be a significant challenge, but that's just being worked through still in parallel.
Thank you. Bill.
Thanks, Chair. So just in terms of London North West, very similar things that Jazz and Virginia have talked through. We are pushing ahead with the contract particulars that we have to do, but we must note that NHS England had to reconsult on the standard contract, and as a result of the earlier feedback, and the consultation doesn't finish until or did only just finish on yesterday, so we don't have the final guidance yet. We did mention that there were issues with NHS SpecCom. We are working closely to review those. There's also a little bit more of a cumbersome process with public health as well that we're just having to work through. We are having to coordinate an IAP, which is an indicative activity plan, and the process around that. That's what Jazz highlighted. We also have to work through our locally agreed prices. That may not happen before we finalise a contract, but it is absolutely something that we must do throughout the financial year, because we haven't run through that process over a period of time.
Thanks, Bill. Virginia, you want to come back in?
Sorry, the one thing Ben was just reminded me, the one thing I didn't mention is around our sexual health contracts. So they're commissioned by local authorities. That is a more challenging conversation given the financial challenges in local authorities, and that is a risk for Chelsea and Imperial, who are subcontract of the same contract. So I just wanted to mention that they are much more challenging conversations around the funding envelopes for sexual health services.
Thank you, Virginia. So, did you want to come back in, Jess?
Sorry, Matthew, just one overarching point again, for all of us actually, for 24-25, I think we signed our contracts in good faith with a number of caveats, probably about signed, but we need to work through these things. And I think we probably failed to do that with the ICB. So our view this year is we should only sign it once we absolutely crystallised it into the contract, rather than having a set of words that were signed off in good faith.
Yes, we hear that. Thank you. Yeah. So I'm going to ask each of the boards now just to confirm their agreement to the sign-off of their organisation's business plans for the coming year, with the areas of risks that have been eloquently described as we go along. So can I just ask for the board members from Imperial to indicate or smiling at me that they are happy to sign off the Imperial? That's a grimace, Tim. You need to do better.
Best I can do. So.
Empty. Thank you. So, Imperial, can I ask Chelsea and Westminster board members? Yes. Thank you very much. And
Yes.
You and Hillingdon.
Yes.
Yeah. Thank you. Okay, all we have to do now is deliver them. Thank you. Thank you very much, and thank you to the people who've done an enormous amount of work in putting this together, and extraordinarily tight timeframes as well as challenging asks. So thank you. Peter, I'm going to move on to delegated authorities to provide committees. I think this paper is for approval, so just want to introduce it to us.
Yeah, thanks, Matthew. So this paper comes with a bit of an apology. You'll remember in the last board in common meeting, we agreed a set of delegated authorities to audit committees and quality committees in order to get through year-end processes. We missed a few bits, so this is just really tidying that up. So we've ensured that we have got the appropriate delegated authority to each of the trust's board committees, including the audit committee and quality committee, not only to sign off the accounts, but also to include sign off of the self-certifications and the modern slavery act statements, which are required as a year-end process. If people are happy to approve those, then we will implement.
Nick,
I had one question. The committee titles are different. Is that simply because we have a two-part committee, which is the non-exec only part of Imperial?
So they all have that common element in terms of an audit committee. They all have that slightly varied approach.
Right.
Thank you. Any other questions on this paper? Can I ask the board's approval then?
Yeah.
Very much. Thank you, Peter. Well done. So let us move on to the IQ Integrated Quality Workforce Performance and Finance report. I mentioned earlier, this still looks like it's last board meeting. There is one new taster slide in there, which is slide 3. If you've got them in the in separate actual page 81 of 328, which is the forward look. What that slide does is pull out effectively the targets that we are contracted for the year that we're now in. We will be restructuring the board pack to take the items on that list and bring it forward so that we can come to where we are on the contract. Then there'll be a section saying what are the things we need to do in order to make it through. Then there'll be the piece on quality, and then there'll be a piece on here are our statutory reports, in order that we make sure that we are focused on those things. You will see that you would expect, given that this is a challenging improvement plan for the coming year, there is quite a lot of red on that chart at the moment, and we will have much joy in working our way forward and watching it all go yellow then green. Leslie, is there anything you wanted to add before I turn to Pippa to do the quality?
No, I think let's just work through it.
Okay. Yes, Pippa, can I turn to you to take us through the quality section?
Yeah, the quality section actually is a positive picture. So we're still showing that we are a high reporter of incidents with a low level of moderate or severe harm, which is exactly the culture that we want to create. Infection control we've talked about, we're not out of sync plus, but the national targets that are set are challenging targets, and we continue to monitor them. We've got above expected levels of experience in all areas, so inpatients, our emergency department and maternity, which is a really positive picture. And we've got very positive mortality scores, as you can see. There's nothing particularly standing out in maternity, like 0.2 above stillbirth rate in month, but not year to date. So again, that's not something that particularly worries us. So really nothing of major concern, I think, to focus on around quality.
Thank you. Any questions around that section? I think we're going to pick up the equity improvement plan at this stage on the agenda, if that's all right. So I think that's Pippa, that's you and Carolyn and Benita. Who's going to? Benita, excellent.
So we're going to do the presentation of the work that the workforce group has undertaken on patient inequality issues. So you'll remember phase 1 focused on staff inequality. This is phase 2. Phase 2 of the work. And we've used the London North West Equity Index to provide statistically validated review of the data of areas that we think we can focus on initially to target, as Matthew mentioned, some really focused work. And this paper will give you a set of 5 recommendations. It will tell you how we've got to those. It will also look at how our work links in with the wider piece of work on inequalities that the ICB is undertaking and our role in that, and put forward also suggested governance mechanisms so that the work can be embedded and also evolve as we go forward. What we're suggesting today isn't the end of the story, it's the beginning, and it becomes the process. But the main thing is that the work was, while Pippa, Caroline and I oversaw it, the main work was undertaken by an extensive team and academically validated as well. And we've got Hannah and Pierce to present. They led a lot of this work, as did Tina, actually, who's left. So I want to thank all of the team for their very hard work on this. And over to Hannah and Pierce.
Hannah, do you want
Do you want me to present the slides? Pippa, was that? Sorry, you broke up.
No, Hannah. You don't need to present the slides. You don't need to share them because we've got them.
No worries, perfect. So hi everyone, I'm Hannah Franklin. I'm the Health Equity Programme Manager at Imperial NHS Trust. I'm going to quickly go over the kind of context of health inequalities in North West London before I hand over to Piers, who's going to talk you through our recommendations. So health inequalities are those unfair and avoidable differences in health across the population and between different groups of society. And we spent a lot of time working with colleagues at our trust, the ICB, patients and community partners to really identify and understand those greatest health inequalities for our North West London population. These include really big gaps in life expectancy, sometimes as big as 20 years for people living within the same borough, more years spent in ill health for certain groups, poor maternal outcomes that you'll hear about later linked to ethnicity, illnesses specific to our really diverse population, such as sickle cell, barriers to accessing healthcare. So the example we've been talking about, outpatient appointments and DNAs, but also the impact that might mean for some people waiting longer. So ultimately they're taking more time to get well again. And we've tried to use this to inform our priorities as an APC, linking back to the ICB priorities and their plans regarding health inequalities. The other bit of major context to kind of put on the page here is the Core 20+5 framework, which you've got in your pack. That's the NHS England's national approach to addressing healthcare inequalities. It asks providers and ICBs to focus on, firstly, the Core 20, which are the 20% most deprived population in your patch. For us, that's 270,000 residents who live in North West London. Then it asks you to think about your plus group. So who else in your local geography might suffer health inequalities? And for us, we've called out our sickle cell patients and particularly our Black and mixed populations. And then there are 5 clinical areas where we have known inequalities where rapid improvements required. These are maternity, mental health, respiratory, particularly the uptake of vaccinations, cancer diagnosis and hypertension to reduce risks of heart attacks and strokes, and smoking cuts across those. This is lots of work that's kind of cross-sector going on with ICB colleagues, particularly primary care and community, but we wanted to be clear on what's our role as an APC to kind of understanding and reducing inequalities, but particularly about prevention and how we can stop ill health happening in these areas in the first place. So I'll hand over to Piers. Thanks, Piers.
Perfect. Thank you very much, everybody. So Hannah's just laid out some of the context. I'm going to talk about some of the actions and things that we're going to do. So in the pack on page 149, you'll see some focus areas. One of the areas where looking at the data, we saw some of the biggest inequities was around access. So in terms of mixed appointments, we know that patients from the most deprived areas are twice as likely to miss their appointments to DNA than those from the least deprived areas. And those from Black ethnic backgrounds are 1.5 times more likely to miss appointments than white patients. And there's a complex mix of societal challenges, and broader issues. And you heard some of those in the video. And the barriers like digital access and letters and texts all disproportionately affect deprived communities. So all the work that's going on around improving communication, is directly targeting some of these. But we're also proposing some targeted interventions. So you heard in the video around the volunteer-led appointment reminder calls, so that being expanding that and aligning across the APC into areas of high DNA rate specialties such as ophthalmology, cardiology, diabetes and endocrinology. And these calls will remind patients to explore and support any barriers to attendance. The next is around waiting time. So we see inequity here, and as an APC we've agreed to apply the equity index methodology, which I'll touch on later, to identify meaningful inequities and waiting times at APC level, organisation and subservice level, and then develop targeted plans to address them. Next is around outcomes and embedding the equity index across the APC. So the equity index is an innovative tool to measure and track equity. It was collaboratively developed at London North West by staff, patients and partners. And you'll see in the pack itself in the detail that this has been independently assessed by statistician at Imperial and public health experts. And they've concluded that it's rigorous approach to measuring equity. It does have its limitations, but those have been mitigated against. And we're currently undergoing and preparing an academic publication for peer review. And that offers a variety of benefits. So helping define local equity and APC equity priorities, tracking impact of interventions, such as our appointment calls, driving improvements in data quality and offering cross APC comparison. What can we learn? Where are the inequities least across the acute providers? Next is around how we're aligning with some of these national frameworks. So Hannah mentions the core 20+5 framework. So a key part of this will be APC alignment about how we're routinely applying deprivation and ethnicity data alongside other protected characteristics when we're looking at clinical performance. And also those 5 national clinical priorities, which Hannah mentioned. We've done some mapping against best practice of these across the APC and a plan for how we can sort of scale these interventions. Finally, moving to some priority populations. So maternity is one of the national core 20+5 priority areas, and we know this is an area with high inequity. In Northwest London, still there's a higher proportion of stillbirths in Black mixed and other ethnicity, 2.8 times those of white mothers. So we're really focusing here on early bookings and, to help reduce risk like stillbirth and preterm birth. And sickle cell disease being one of our plus populations areas of focus, and we know there's long-standing systemic discrimination there. Each of these areas, maternity and sickle cell, do have mature governance structures in themselves, and some of those are detailed in the pack itself, so we'll be taking more of a supporting role and how we can ensure ongoing commitment to sustained improvement. The next slide goes into some of the recommendations. A lot of these I've talked about. So the first is really that focus on access, outpatient appointments and wait times, formalizing our alignment with a core 20 approach, remaining cited on existing equity improvement across sickle cell and maternity, and the equity index as a shared tool. We're also adopting 4 performance metrics across the APC. So the first is around the did not attends, the missed appointment rates, and I've talked about why that's so important and the high level of inequity and how it supports that. The next is around the 40+ week waits. We know that long waits are cause issues for some of our most deprived groups. Next is around maternity bookings. So we know that by improving early bookings, so 9+6 weeks for Black mixed and other ethnic groups, we can reduce those risks of stillbirths and preterm risks. And finally, around timely sickle cell analgesia. So sickle cell crises, which are extremely painful episodes, how can we ensure that pain relief is given within 30 minutes of arrival to address, the pain, but also some of the historically poor emergency response. And each of these will be embedded into the integrated performance report, but also overseen, the DNAs and 40+ weeks will be overseen by the finance and performance committees, and maternity and the sickle cell analgesia by the APC quality groups. So that gives an overview of some of the work. And as I said, there's a pack with a lot more detail beneath each of those areas.
Thank you. This is outstanding work. It follows on from us having done an equally rigorous piece of work around our staff and staff equity and a programme already being in place. So thank you for the team for picking that up. So I'm going to come to Sim and then Aman and then Sim.
Matthew, you've stolen the words out of my mouth. I just want to congratulate the team for this excellent piece of work. And 2 things struck me. There's a mistake in inclusion work that usually goes, let's look outward and externally and see how we can change things before looking internally at our own provision, how we treat our own people, our own staff, and how we think about inclusion ourselves as leaders. So as Matthew said, we did that first piece of work properly to help us inform going out into our communities and helping them. So that's really important. The other thing for me that struck me is, inclusion work is all about, there's a lot of good intention, always. Obviously, organisations want to do their best, but this doesn't necessarily turn into impact, and it doesn't turn into sort of progress or development. So what I'm really pleased with are the focused performance metrics that you've got at 0.5. That will give us our tracking ability to track. We've identified things that we have under our control. And the other thing is accountability. If there's accountability, there's improvement and there's impact. And I think really we've come up with all of these things. So thank you. This is really important work, vital. And we mustn't forget we're not in this alone. I'm afraid it's an ICB, a system remit, that they must also work on population health and inequality. So this, together with the work being done there, should deliver for our population. It's really exciting. Thank you.
Very good. Thank you. Aman, Tim, Carolyn.
So I wanted to pick up on the point that Sim made last point, which is, does this translate into impact? And as you know, Matthew, I have been probing issues with regard to deaths in maternity, stillbirths and all of that, both at Chelwest and at Imperial for the last 2 years. And I keep on being told, well, we haven't got the data, it has to be looked at nationally. It would appear that we do have some data here. And I cannot understand why that is now not translating into impact. It's been going on for so long.
Tim.
So I think this is really excellent work. I mean, it really is. I think it's very helpful to have the equity index as a single number. I think it would be really helpful for us as we move forward to understand what it's telling us. And I think testing the assumptions that underlie it, so that if you change one variable, understanding what the impact that has on the equity indexing is going to be a really important issue for us. I think and my second point actually is around part of the maternity issue. The maternity issue is absolutely a key joint priority for us and the ICB. It has to be, because a lot of the issues around the outcomes of maternity are determined and the early part of maternity. So I think the aspiration about the booking time is one. But I think my slight concern is, having been at some ICB meetings recently, if we're not careful, we may not have the levers to make some of these changes. A, to record the data early in pregnancy, and B, to make the changes. The third thing is, and I would say this wouldn't, I think this absolutely needs to come through the APC EMB so that we can get an overview of what we're doing. And I think the APC EMB, I think, could really usefully see the plans that sit underneath the 4 points, which then will help us to work out what is going to have impact. So I think that will be a really key thing. I think that the plans are excellent.
Carolyn.
So that's impact again comments. So for me, I think both the staffing ones and the recommendations, and these recommendations should come every 6 months to our standing committees, so we can actually check what we are actually achieving with, because sometimes with these issues, I think we agree them, everybody says it's brilliant, and then people go move on to the next thing. So I think we've got to really bring this back and monitor it.
I'm assuming we're going to work this into our standard performance plan. So every time it goes to each of the groups, and when it comes to standing committees, we'll be able to point it out. But I think I take your point very strongly.
I kind of get that, definitely. I just sometimes think that our performance conversations are a little disjointed, because we have one conversation at one committee, another at another, etc., and we don't really necessarily pull it all together. So I think, as I say, it might be that we just do it annually or whatever, I don't know. But I think we need a collective, holistic conversation about equalities.
Thank you.
Yeah.
Thank you.
Can I just start?
Sorry. Catherine, Linda.
Well, firstly to say it's a lovely piece of work and really nicely presented. But reading it, it's quite high level. And I was really happy to hear that you're working with public health statisticians to publish some academic papers as well, because I think it's really important to have ongoing audit and evaluation. Because many of these, even the 5 priorities, are very, very complex. There's not just one intervention that's going to make a difference. And a number of them will overlap. So vaccination is going to be very, very important to reduce maternal deaths and stillbirth as well. So I think rigorous evaluation, if we could see the metrics reported back to the board, that would be really helpful. There are some other metrics that could be helpful. It hasn't been mentioned, but is a health economic analysis being done as well? Because that could be quite helpful to drive the initiatives. And working with
Imperial again, implementation scientists can look maybe at how some of the interventions land and how to make them land better.
Thank you. I'm going to take Linda at the meeting, then I'm going to wrap up. So, Linda.
A couple of points. Echo everyone's opinion that it's really good work and really pleased to see people looking inwards. Minor point, sorry if I missed this, but just be interested to see the impact of this kind of holistic work in terms of when we consider harm in terms of patients and validation of waiting lists and just how that's included in it. But a second really practical point, perhaps I'll get in touch with you afterwards, is just how we're sharing this, because I think a lot of trusts just look outwards and say, oh, it's the ICB. And I personally would really welcome sharing this and sharing your names, but I don't want to overload you, because there's models here that really could be used across other systems as well, and actually collectively would even be better.
Thank you. Pat.
Mine was a very simplistic point, and it was back to the quality about seeing what those slides are actually going to look like and what we're actually going to be measuring. It's very, I think at the quality meetings we need to sit and say is actually this is good or that is bad, and be really clear, because I don't think my reading, I didn't see that clearly in here.
Denise, and then last word for Pippa.
The group was very focused on impact and performance, so we've gone as far as we could at this stage of the work, but that focus remains. So I think that we're talking about governance, part of it going through finance and planning, part going through quality, then to commons and also trust standing committees. That's the recommendation of the proposal. Doesn't mean to say it can't be changed after a time, and we can review that. And I think also some of the points that people have made about different areas of work that need to be looked at, that can also be brought up through that process. But the other point I wanted to make is we've talked about our understanding of how the APC fits in with the wider system. And while we are focused on impact and performance, I think, like Sim, I'm familiar with the fact that it may not always be the case elsewhere. And I think part of our oversight role with the ICB and the peace streams of work that they're doing, I think as we embed our performance measurement, we really need to share that to make sure that a lot of this inequalities work's happening there. And I think it's incumbent upon us to do that rather than wait for them to do it, because it hasn't happened so far. But we need to develop, carry on and spread.
Thank you. Pippa, last word.
Yeah, I think great questions. A huge thank you to particularly Hannah and Piers, who have driven an awful lot of this. What it shows is there was great work going on in each organisation actually, and there was just a brilliant shared learning and bringing it all together. In terms of sharing, Linda, we did a lot of engaging across the country actually. We had some presentations from other parts of the country like Calderdale and Huddersfield have done a different approach to it. They're actually sharing our equity index now. We're using a bit of what they're using. So it has brought a little network together actually of acute trusts that are doing this in different approaches and using different ways of doing it. So we've already started that, and certainly Piers and Hannah are very linked into with them teams. Imperial College have been really supportive, Catherine. I have to say they've been quite behind this, really engaged with we wanted the assurance and the validation of the equity index tool, and they've really put themselves out to do that work for us. So they are very behind us and very working with us. I think the implementation scientist is actually quite key now of how can we get some of this work delivered. And as Vanita says, we really pulled it back to let's just pick 4 things. You could pick so many things in this area and actually achieve nothing. So let's just pick 4 that are measurable, that we can have in our IQPR, and then let's work with them for a year, see where we get, and then we might want to iterate that. But we really, we started off with a long list. We boiled it down to 4 things that would make the biggest difference. And then
thank you. Perfect. So I think all hugely welcome to this. We need to integrate it into our reporting and make sure that it's part of what we discuss and move forward. Let me echo the thanks to Piers and Hannah for this work and to the committee that took this on. Great. Thank you very much. Let's move on to the John, learning from deaths, the Q3.
Thank you.
Sorry.
Can I go back just on?
Oh, sorry, I missed you.
Yeah, you missed my hand. It relates to the business plans. It's my thing I always mention, which is about discharge and the time. I notice in the forward performance that it's grey because we can't determine what the targets are going to be. But we always talk about the front door. We need to keep in mind the back door of discharge. And in order to be able to achieve our business plan, we're going to have to get people out of hospital as quickly as possible. And we talked about the link with the ICB. And colleagues will know that local authorities are critical for that, and we don't have that lever of control. So engaging with local authorities, we talk about getting the ICB to present to the board, but I also think we need local authorities here to understand the pressure that we're under in order to get people discharged. And so my question is, how are we going to determine what those targets are and measure them? Thank you, Matthew.
We're going to come to the performance. Let's get James to pick that up under the emergency section later on. We'll if that's all right. But wouldn't work well made. John, learning from deaths.
Thanks, Chair. Right, just to recap, this is the report for mortality, which is looking at the reporting period that finishes July 24. And to remind everybody, there's two measures that we're looking at in the main, the SHIMI and the HSMR. And we also triangulate with our level 2 mortality reviews, which do in-depth analysis of any concerns. In this period, Hillingdon did spike above 100, and also London North West went into the as expected range. Chel West and Imperial remained below. We have had recent sets of data just to assure the board where both Hillingdon and London North West have dropped back down into the lower range since then. And also to note, which I've mentioned in the report, is the December period saw a change in the methodology of HSMR, which caused some fluctuation around the country in that period as well. SHIMI did not have any changes in methodology, and all the trusts remained in the as expected or lower than expected range in the SHIMI measure. Finally, the level 2 reviews remained strong with low levels of harm reported in those, which is a good triangulation. So in summary, yet mortality remains low across the region, but there was a spike which has now resolved in the later releases of the data sets with HSMR. Thank you, Chair.
Great, thanks, John. Any questions?
I've just got it's probably a really stupid question, so apologies if it is, and do say so. Feel free. But we've taken out Queen Charlotte's and Chelsea Hospital and Mount Vernon because of the very, very low number of deaths, which I totally understand that because it will support figures. But how do we therefore keep on top of that? How do we know if those are taken out? How do we, I would say as non-executives, know?
So all the sites continued to run their internal processes, which we then review through our mortality group as well, with any spikes there. So as in, there are reviews of deaths still ongoing. It's just that the numbers and the numbers will still go into overall stats. It's just that we're not looking at them on a site basis. So they're not going into the HSMR or SHIMI. We're just not pulling them out separately by site because you get a very skewed data set if you look at the site individually.
Great, thank you very much. Nick.
So I have one quick question. On the level 2 reviews, I think it's historical from having been at Chelsea, but Chelsea's looking at 44% compared with 16, 7 and 18. And I just wondered what that divergence is explained by.
There's just a slight Chelsea, well, Roger can explain, but there's a slightly different set of triggers, which is fractionally more inclusive, which Chelsea use separately. But Roger, did you want to expand?
Yeah, I should do. And Nick, you know from your time as a NED in our trust that we've had quite a rigorous approach to mortality surveillance, which we took the new approach that the APC is doing together to our clinical group. They actually wanted to keep the increased level of rigour, which is why we continue to report more and to have more scrutiny.
And that conversation go around the loop again, as in, if Chelsea think they're doing it better, then why aren't we all doing it like that? It feels a bit uncomfortable as chair of 4 trusts to hear that one doesn't think the way the other 3 are doing it is right.
I think
we can have that at APC. We need to standardise it. We need to work out a way forward, but we can do that at APC, I think, and do that.
Yeah. Just to reiterate, I mean, I don't think the other trusts are doing any less than anywhere across the country is. It's just they've got into a rhythm. It was more of a rhythm
exactly.
that they used it as part of their development and learning and sharing. There are other things that the other trusts do, to be honest, that capture other areas of learning.
But one advantage of the collaborative is being able to look at what's going on across them, and if we count things differently, we can't see what's going on.
I don't disagree, but you could say everybody should do everything that everybody else is doing. It would be the.
We should measure everything the same. You can then choose to do it differently, providing your outcomes.
I think that's so. Anyway, I'll shut up because I'll be on safe ground.
Thanks for that. Can I move us on to the EOC?
I'm going to hand over to Mark, actually, who's the Managing Director for the EOC. He's on.
Oh, excellent.
Thank you. Yeah, I'll just give a couple of headlines for the report. It's still just under a year actually since the EOC was fully open, but we've got the sort of first year of activity to go through here. We provided a bit of a flavour both in terms of the levels of activity going through and also some of the clinical outcomes. Included within that is the impact that it's having on the overall orthopaedic PTL waiting list across North West London. And in particular, the efforts that are going on to reduce the sort of inequities effectively within that. So some really good examples over the winter months in particular where, for example, Hillingdon surgeons were operating on London North West long waiting patients to help even up that balance across the four trusts and the opportunity to develop that work as we move forward towards effectively a sort of single waiting list approach and more pooling and sharing across surgeons. Included in there is an update on the Getting It Right First Time, the GIRFT accreditation, which occurred in November last year. We've just had the follow-up visit in the last couple of weeks from that, and we're well set now at the Orthopaedic Centre with the next site visit from Professor Briggs and team scheduled for 2027, and we're now within their routine reporting. A little bit on the current EOC governance processes with the monthly partnership board, where we have clinical directors from all four partners, chaired by my colleague Matt Bartlett, and that reports into the APC EMB monthly. And then finally, we've included just at the end of the report a little bit of a extract from a lessons identified paper that we were asked to produce through the finance and performance work stream, particularly to inform potentially development of future shared services models. We've just highlighted some of the challenges and some of the takeaways from the implementation and mobilisation of the EOC process to help potentially future shared services as they develop. I'll stop there, but happy to take any questions.
Great, thank you. Any questions? Well,
thank you. Thank you very much indeed for the update report. There's in the section that talks about the EOC operating plan 6, it flags as an yet unresolved agreement as to activity and financial flows 5/6. And I just wondered, in the context of our earlier conversation about the tightness of the 5/6 plan and delivery, when that might be resolved.
So we've had continuing to have conversations. So we've set the plan on the continuation of this year's plan. Not an increase, but we haven't decreased. At one point in this planning round, we were looking at decreasing the activity through the elective orthopaedic centre, which actually none of us agreed with, but that was what the financial envelope looked like we could afford. We are continuing the conversations around, there's about £8 million additional funding that would need to come to carry on to deliver this on plan, and that's the conversations we're having with the ICB. And that's what we need to know in the before the 8th of May.
Thank you. Helen.
It seems a bit of a no-brainer to me, and forgive me if we've gone through this at different times, but it looks to good. It's community-based, it's positive. What is stopping people from referring to it and using it? I don't understand.
I don't think there's anything stopping, but there are lists that exist in the home trusts, and actually what you can do is put on simple cases with complex cases to utilise your list for it. So you can't really remove every single simple high volume, low complexity case out of every trust, because it removes the flexibility and you end up with lost operating times in the home trust. So everybody needs these simple procedures that you can tag onto the end, and you can get another case done at the end of a conference. So there's some of that happening. There is some of the slight issues around how each trust individually manages their patient treatment list. So some manage it per consultant, some pool it across consultants, and that's given a little, we need to work through all of that to make sure there's more of a flexibility of patients that can come to the elective orthopaedic centre. I mean, what is positive, you've got to remember this is 1 year and it's a big change. 28 consultants from other trusts have operated in this centre. So that's a huge volume of consultants that actually have come on board and are operating in this centre, and over 3,000 patients. So, you know, it's big numbers actually that in quite a short amount of time have changed their practice. Do I think we're in a finished place? No. And does it take longer to change culture and practice? Yes, it does. And we all need to, you know, carry on the journey with that. But I think there is a bit of the plan was probably set too ambitious at the start of, did we ever think we were going to start with 4 patients per list, which is the best standard ever? We weren't even doing that in our home trust. So did we think we were going to do that from the start? No. And did we think we were going to move all patients from all trusts into this pathway at the start? No. But that's not how the plan was set. So I think the model we've got to now still takes quite a lot of work to get them numbers through from each trust, and it takes a lot of engagement, but that's right, that's how these setups work. So I don't think we're there yet, but I think there are other complexities, and we do need to keep some of the more simple patients, less complex surgery at the home trust as well.
Yeah, I'm going to take Carolyn, then I'm going to take Mike, and then I'm going to give Mark the last word.
Okay, so I think this is really good stuff, and this is actually about changing a pathway radically. However, if you look at the statistics within this, of the 3,063 patients who had surgery, 2,300 were from London Northwest. So my question would be, and then if you look then down at the table, which is blue and orange, and you look across that, and you can see that there's over 1,000 in the other trusts waiting, and I'm just kind of wondering, what can we do to square that circle?
And it's on a similar point really, so I'll keep it fairly brief, but the report talks about a significant risk in terms of the level of referrals and this having to be cancelled at a great position. So my question was a bit more detail about what is it that we are doing or can do to get the numbers up. And both sitting line that if it's about different referral arrangements across the APC, do we need to be a bit more radical on it and you know, push that a bit harder really, because obviously not necessarily great for patients, but also it will flow through into costs and efficiency as well.
Thank you. Mark, I'm going to let you pick up that. What are we going to need to do to really squeeze the benefit out of this in your wrap-up words?
Yep. Yeah. Can pick up those two questions. Part of it is about, and we allude to it in the cover note, removing some of the variability, particularly around the POA process. So we've, as people know, this is a model where the patient only comes on the day of surgery. That's quite different to some of the other EOCs where they do it differently. So we keep the patient close to the home trust in the community, which is absolutely the best for the patient, and that's, you know, exactly what Gerft saw. But in terms of that, does mean we've had to work very hard at that pre-op process to make sure that it's as sort of slick as possible, particularly working with things like different pathology providers. We've done a lot of work on that, but there's more to do. So there's variability we can take out there to make sure that it's as easy as possible for the patients to be referred through and to get onto the EOC list as quickly as possible. And the other area where we can progress more is around both case mix, so continuing to review the range of low, effectively less complex work to bring through the EOC, and we're doing that and talking to the partners about that at the moment. So there's the opportunity to increase that further, and also to then progress the sharing and pooling of patients in the way that we've managed to achieve over the winter period with Hillingdon seeing some of London North West long waiting patients. And if we take that forward, then that will also increase the activity throughput.
Thank you. Thank you for that. Thank you for the report. I think you will feel the sense of both satisfaction at where we've got to and urgency about where we could get to on it, Mark. So thanks for your work on it. And I'm going to move us on to the last item on the quality section, which is anything perhaps from the quality committee that you want to highlight.
Just everything listed there, and we've sort of talked about it in the earlier part of the meeting.
Great, thank you very much. I'm going to move on to you. You will notice, and I'm happy to take feedback afterwards, that we've tried to cluster topics that are the same together. So instead of going just through the performance report, we've brought together all the quality stuff, and now we're about to go on to the stuff that's around workforce, and then which does mean you have to flip backwards and forwards in your pack to get to the charts that we're talking about. It makes it easier to chair. I don't know if it's in the meeting matters, and that's all that matters. You can say that. So, Pippa, anything in the workforce performance report that you want to raise?
Kevin, do you want to take it?
Yeah, happy. On the KPIs, they're in relatively good positions in terms of vacancies, turnover, agency, and core skills. Sickness is nearly there. The areas that we're focusing on, which is a bit more variable, was the appraisals, but Chelsea and Westminster have now introduced the window, which we're looking to focus on there. So that hopefully has help. And then we didn't actually talk in the previous item about equity around the actual workforce element of that. You know, part of the reason we have the model employer goals of getting more representation in the workforce is because that will help a more responsive and understanding of our patients. And I think there's a workforce piece that we need to pick up on that, but I didn't want to discussion under that item. And the biggest challenge, which doesn't be seen on the IQPR, is actually the workforce numbers and the staffing and the pay. But we talked about that in the market section, but that is really the Trust's focus now, is really on getting that pay bill down into the workforce numbers that we need to deliver, but not losing all of our good work on staffing elements and the staff survey.
Yeah, thank you for that. I think we've exchanged some emails with Tracy as well about as we move the pack forward, we need to pick up some of those as proposals, but also these model employer goals, we need some trends on, because I can't tell whether this is if we get the workforce staying the same. It's a snapshot. So I think that's some thought about how we present this so we can see where we're improving. Excellent. Any questions? Okay. Thank you very much, Kevin. And let's move on to Sim. Will you report back from the People Committee in David's absence?
Yes, absolutely. So hopefully you've taken the paper as read, and I think we've talked, Kevin sort of eloquently just talked about some of the good things. You know, the workforce is in a good place in regards to its metrics. There are some sticky areas that we are hyper focused on that we pick up in there. That's violence, aggression, bullying, harassment, discrimination, and flexible working. And of course, the key issue around the workforce is exactly as Kevin has read, our ability to be able to look at productivity and track that. And this call on the reduction of 50% on the corporate numbers. So you've got this tightening and this clarity over the workforce and delivering workforce within our financial constraints, but against a backdrop of good staff experience in general across most of our trusts. And we have to somehow, and the chief executives have to balance this off, because we must maintain the goodwill in order to keep up the productivity, in order to keep up patient experience and safety, but at the same time squeeze. So there's a bit of a dichotomy going on within workforce, and it's delicate, it is managing, and we must help our staff maintain their morale. Because obviously they're getting a lot of information from other sources, so it's really important to be clear about what we're doing, why we're doing it, and how we're doing it, and making sure we look at the impact of any decision.
Thank you. Any questions on that? Okay, thank you very much. Thank you, Sim. So let's move on to finance and performance. Is there anything you want to add, or can I throw this across to James to walk us through the sections?
I think, James, if you just pick out anything you want to pick out from each coordinator.
Thank you. James Walters, Chief Operating Officer from London North West. So we have the February performance data, say for cancer, maternity and the operational plan, which is January data. I will take us through cancer. Claire from Imperial will take us through urgent and emergency care and discharge, although we will pick up Simon's question either along the way or towards the end. And Laura from Chel West will pick up RTT and diagnostics. So I'll turn to Claire first to follow the order in the performance pack for UEC and discharge. Over to you, Claire.
Thanks, everyone. As James said, this is the performance report for month 11, but we now actually have our month 12 data. So we'll touch on that as it's relevant if there's something different as we go through our narrative. For urgent and emergency care, I'm happy to say the month 12 data does show an improvement on January and February. So collectively, we achieved 77.7% of patients treated in our emergency departments within 4 hours for that month, with Chelsea and London North West hitting the 78% target and Hillingdon and Imperial not quite getting there, but also delivering an improvement on previous months. That improvement was largely driven by the plans that we've got in place, the actions that we've spoken about here, making sure that we improve our pathways as we go along. And clearly, we'll now be looking at making sure some of those changes are sustainable. Our ambulance handover performance also improved in March. We continue to have the best ambulance handover times collectively in London. There is still some challenge across some of the individual organisations, so some variation in performance, with London North West having the most difficulty with their handovers. And in the month of March, actually, we introduced a temporary arrangement to support Northwick Park in particular at their peak point towards the end of the afternoon to try and reduce the number of patients that they needed to look after in their ambulance cohorting area. And that was designed to do two things. So one was an immediate reduction in the pressure, and the other was to give Northwick Park some time to think about their pathways and work out how they could more sustainably manage that demand in the future. So the immediate changes had an impact. Ambulance handover times improved, and we're continuing to work now together to make sure that the pathways collectively work better going forward, and that temporary change that we had put into place has now stopped. In terms of our long wait performance in the emergency departments, that has also improved in March, and it's the best it has been since the summer of last year. Definitely still not where we would want it to be, so there's a lot more work to do, and that work I think is twofold. So bearing in mind that this indicator predominantly measures pressures across the hospital, so it tends to be about flow and bed capacity and bed availability rather than processes within the emergency department per se. So we're continuing with all of our internal work to make sure that our pathways run as smoothly as possible and that patients get timely care as they go through. Then the second piece of it is around working with our partners, and there are two strands to that. So one is we still have significant challenges around mental health and patients that are waiting for transfer to mental health beds, although there is a huge amount of collective action and focus on that at the moment. And then the second piece to that is our work with the community bed providers and with the local authorities to improve our discharge, so that those patients who, when they reach the point where they don't need our acute care anymore, can move on to the next setting that they need to be in as quickly as possible. There has been some improvement in that area, although at the moment that improvement is varied and it is not consistent, and different organisations experience particular challenges at different times. So during the month of March, there were some specific challenges for London North West and for Chelsea that we need to work through. But overall, there's a set of agreed and aligned actions and things that we're working on to make those pathways work better. They range from making sure that we're all using an IT system we have called Optica, which means that across the whole system, we can look at where the delays are and work together to unblock them. And also working very closely with our care homes to make sure that we've got the right capacity in place to deal with the demand that is coming through our system. And that's all I shall say on urgent and emergency care for now. I'm happy to take questions in a moment, but first I'll hand over to Laura, who's going to talk about elective performance.
Thank you. So I'll start with RTT. Positive performance in the pack around long waiters. So we're continuing to see a reduction in the number of patients waiting over 52 weeks for treatment. We know there are some particular challenges in certain specialties with very long waits, but this is reflective of the national picture and challenges across the country. We have discussed earlier, so I won't go back over it again, the asks in the operating plan for 25-26, but that's to continue to reduce the number of patients waiting over 52 weeks and also to improve our 18-week compliance to 60% across the collaborative. We each have individual detailed productivity plans in place to deliver this, focused on improving productivity and maximising the capacity that's available to treat these patients. I'll go on to DMO1. So in terms of diagnostic performance, the board will be cited that DMO1 has been challenged across all organisations across the year. We have seen this performance stabilise, but we remain uncompliant due to the reasons outlined, including capacity challenges and reliance on insourcing and outsourcing. This does remain a risk going into 25-26, and our operating plan submission set out that we would not return to compliance over the next 12 months. Saying that, similar to RTT, we will make every effort to ensure that productivity is maximised, that we're using capacity that we have, and that we're maximising use of the CDCs, but we're not likely to see an improvement in the coming months over the performance reported in the position. I think that's me, James, and you for cancer.
Thank you, Laura. Cancer performance, the first standard, our faster diagnosis standard, we have achieved at the collaborative level, being above the 75% line. As a forward look for February, I can confirm February's performance was 83%, which is the best we've seen since December 2021. So a real strong performance as we start to exit winter on our cancer services and their accessibility. On the 31-day standard, we achieved again at collaborative level, and 62-day, whilst we achieved against the London level performance of 70%, achieving 75%. We haven't yet achieved the 85%, which is our North West London aspiration, and indeed the shared aspiration with our Cancer Alliance RM partners. But the green shoots are there. London North West 84.1%. We've seen 85% be achieved by at least two of the collaborative organisations over the months of the year, so that we know that is achievable. And as we strengthen workforce productivity and many of the things that we touched upon in the operating plan, we think that will also give us the priority that cancer pathways and cancer patients deserve. So an improving picture, I would say, on cancer, and RMP, our Cancer Alliance, continues to be the best or one of performers nationally and regionally. Shall I touch upon discharge? Yes. In relation to assignments? And Claire wisely mentioned our utilisation of digital tools, which are within the federated data platform, one of which is Optica, and that allows us not only to capture more granular information about discharge and the reason for the delay, it also allows us later on this year to start sharing close to real-time data with our local authority colleagues. And there are some reasons to be cautious here: the availability of public funds going forward, and indeed we often see the most complex patients have a slightly longer delay in hospital. And if you think about wider society and the holistic view of discharge, homelessness, mental health care, cost of living, and various other factors play in here, availability of housing, and so on, all things that our teams are working daily with for huge numbers of patients across our different hospitals as they discharge. And thinking about, as a system, what we're doing about that, starting very close to home, each of the acute trust monitors time of day for discharge to try and get patients home earlier. We monitor continuity of care to try and preserve that and the handover to community or other partner services. And indeed, we monitor the day one discharge planning to make sure that we are focused for those more complex patients that I mentioned, that they are getting the right consultant and senior reviews in hospital, because that is crucial. Community services are working on one consistent offer, which we expect to be in place this year, which will really start to give our ward teams certainty about the availability of community IVs, the availability of community rehab, the access to community beds, and the services that we offer in the community via district nurses. So that will really help. We've tried for many years to have a directory of services, but there are and there continues to be some variability at borough level, and this standardised community offer will often offer consistency, and that will be absolutely well received by our team. We continue to work with the ICB around continuing healthcare funding and trusted assessment models to try and streamline those patients that need that ongoing care and how that is paid for, assessed and put in appropriately at community level. And then probably the most critical partner, our local authority. We continue to have regular meetings through the integrated care partnerships where we talk about better care fund and availability of resources and how that is spent, particularly over the winter period. So some good improvements and progress on digital, some work with community services and some work with the ICB and other partners in our community through the integrated care partnership. Final thing to say is GPs, and we touched upon some of the work in the Brent Back to Health initiative that we saw earlier on today, but we meet regularly for interface meetings with GPs where they raise concerns or questions about discharge, and likewise we raise the type of support that we hope to see through integrated neighbourhood teams to support patients out of hospital and try and prevent readmission and things like that. Consistency of rapid response teams in the community we think will further help there. So it's not perfect. There are reasons to be cautious about our optimism, but there is a lot of work going on at each layer of the community to continue to improve discharges.
Thank you. Any questions? Okay.
Thank you, and I appreciate it's outside of control, and that's really good to hear. I guess the question that I had as well was, how are we going to determine what our, in the forward look, what our targets are around that area?
Yeah, so I think that's a very a good point. One of the questions we've asked the ICB is in terms of the allocation of the Better Care Fund, which is a lot of the funding goes into, and it's a lot of money, goes into the ongoing care of these patients, is what metrics are you putting to that for each local authority and for each trust? I mean, there are internal things that we need to do on Pathway Zero. All of us are setting a trajectory for, but what I've asked for is a trajectory for each pathway 1, 2 and 3 by borough.
I think the input element of it is important, but the output element of it is, what have we planned our beds for the coming year based on? Is it an assumption that it'll get no worse? In which case we should draw that straight line and have a chart which tells us whether it's got worse or got better. Is it that it will improve by 10%, in which case we should have a chart which has that as the trajectory and see whether it really has happened. Tim.
So I just wanted to make a comment about the cancer.
Okay, let's
just about the discharge. I think it's a really important area, and thank you for bringing it up. I just wonder if at some point, and I don't know where the right forum, a bit of a deep dive into the discharge, including looking at failed discharges and our learning from that. Maybe it's up through the quality committees, but I just think it is a really key area for us. It's not one that comes through routinely.
I mean, we could circulate maybe the paper. So we have a system board. Sorry, I couldn't remember what it's called. I chair it, but I couldn't remember what it's called. We'll do as a first bit. We'll send you a set of papers because there's a heck of a detail in there about
it's like lots.
Yeah.
Thank you. Tim Cantor.
Yeah, I mean, just to highlight, so I think an agency would do really well on cancer. I think the FDS performance is good, and as James says, RMP is the best cancer network in the country. Thing I think we just need to bear in mind is that although we meet the FDS, so we can include or exclude on average a cancer diagnosis within 28 days of referral in over 75% of cases. The difference between people who don't have cancer in that pathway and people who do have cancer is enormous. So our aspiration, I think, for this year is to make sure that we get as close to 75% of people who do have cancer as people who don't, because the difference is 20 or 30%. It's quite significant. And of course, if you think about how do we improve our 62-day performance, key part of that is making sure we get the diagnosis early in the pathway. So just to highlight that as an area we need to focus on. Again,
I'm just wondering how you would know that before you'd done the diagnosis bit.
You know, looking backwards, though.
Yeah.
It's always going to be.
Okay, thank you. Can I move us on to the finance?
So I think we're not going to say too much. We covered a lot. Jazz, I'll leave it to you about anything you want to cover.
Yeah, no, I was going to say monthly 11 reports have been taken straight. It feels very old now, given the time we have. So I suppose you touched on it earlier on, Chair, in terms of year end. So the draft unaudited accounts for the APC show a deficit of 49.8 million, which is marginally better than the one that we had been predicting for a number of months. Obviously, a lot of that was underpinned by the health plans that we all had in place, which were back-ended into month 12, which have materialised. And actually, that performance does also include about £72 million worth of on elective recovery funding against the plan that we'd set at the beginning of the year. And that was maintained actually quite consistently throughout the year. So I wasn't going to say anything more.
No.
We just wait for the auditors to go through.
Thank you. Karen, do you want?
I've got nothing to add either, Chair. Thank you.
On the finance committee, thank you very much. In which case, we will move on to briefly from the Digital Data Committee. You can see that we are escalating here. There's work being done on the business case for a data warehouse. There is a full draft cybersecurity strategy is in the reading room for people who are interested in that kind of thing. I think for those people who are listening to the radio, reading the news yesterday, there was a whole big push around the NHS app, and we have had a quite long conversation because we use two tools in the trust as well as the NHS app. We use the Care Information Exchange and we use Doctor for communicating with our patients. Big push from the committee to say we should do that all through the NHS app. Why aren't we allowed around that? Particularly as those two contracts come to an end in a year's time and we'll have to continue to pay for them. We don't do so by now. Wasn't completely clear listening to the ministers on the telly yesterday. They understood that the NHS app doesn't currently do all the things that the Care Information Exchange and Doctor do, and we are probably the most advanced in the country in digital communication with patients about upcoming appointments. And so we are very enthusiastic that the NHS app in the next 12 months should be able to provide those actual pieces of functionality in order that we can standardise around a single experience rather than having to use multiple different apps to get different things out of the trust. So that is on our roadmap, but slightly outside our control at the moment. Sid.
Just a quick question, Matthew. Though, in the meanwhile, whilst we're renegotiating those contracts, could there be a single point of access for our patients so that they can access Doctor through the NHS app? Is that a possibility?
That's not currently something that you can do. It might be the answer that the NHS app team come up with. We don't build the functionality, we enable other things to it. But at the moment, if you want to access your electronic health record, you would go in through the NHS app. If you wanted to renew a GP prescription, you would do it through the NHS app. If you want to cancel your outpatient appointment, you'd do it through Doctor. So we need this. I mean, there's a lot of progress has been made around the NHS app, but there's still work to do to reality. Thank you. Right, I shall move us on to Bob and the estates, infrastructure and sustainability.
I mean, I hope the report is self-explanatory about the area covered. I mean, I would commend the work that's been going on about bringing together the green plan outputs across the four organisations. It's far more it's far more consistent in like reporting. The evidence is there. It's a news story across the board. We need to do better about linking the economics to it, but people are up for doing that. At Aman's point that he made earlier about the granularity of capital planning across the piece, yes, we'll bring it back into the estates and infrastructure and make sure that we have granularity of it there at a collaborative level. But I still expect it to be pretty granular in the individual organisations' finance and capital planning. So I think that's that. And other than that, a focus on contingency planning, which might be trust specific, but we were very minded to ensure we were clear about that.
Any questions for the? Very good, thank you for that, Bob. I will move us on now to the item 7, the report from the executives, and let me come to Tim.
This is for the APC EMB. So the paper is there. I've got a huge amount to add. We've been largely focused on landing the 24-25 financial position and then the signing off 25-26 position. I think good news in terms of the clinical pathways. So 27 of the 28 pathways we do now have implementation, proper implementation plans with metrics, which is good. Our view is that rather than just sort of now abandon them, we need to follow these through and make sure they actually deliver, and then work out what the next set of pathways that we want to focus on are. Some scintillating stuff around governance, as always. And I think a quite helpful list of stuff that we are doing across the collaborative, just to, they sound sort of quite transactional, but they are further evidence of people working together. So collaborative, the courier contract across the whole of the collaborative, data strategy you just mentioned, Chair, a single approach to Cerner, EPR training, principles for joint learning responses from patient safety incidents, EOC. So I think continue to focus on those things. The other issue, which of course is flagged and will have much more focus this year, is the non-clinical corporate functions and how we can bring those more effectively and speedily together.
Very good. Any questions?
Yeah, thanks for that, Tim. It's good to hear that as well. 2.4 is APC clinical pathways. I'm just wondering when we might get something about that coming to the board.
Well, very shortly. So essentially, we've now got, as I say, 27 out of the
28
are now at an implementation phase. So we can share with them what pathway changes are, what we'll be measuring.
That will be helpful. Thank you.
It's going out of character. We're slightly hiding our light under a bushel on those programmes. As I did people's appraisals, it became clear to me that actually there's quite a lot of progress being made in that, and we're probably not shining quite as much light on what good work our clinicians are doing working together. So it would be good to bring that report.
Tim, can I just ask you about virtual ward under 2.6?
Yes.
I think it's one of the areas being looked at, and I think when they first came into being, they were heralded as the sort of, the great help, if you like, in terms of moving stuff into the community. But from your point of view and from the APC's point of view, are they effective? Is it just pulling staff into a multidisciplinary team away from our sites? Is there any more that can be done? Greater impact? Is this a way forward for us? Or
so so interesting, they're working well. And I was a bit of a virtual ward skeptic. But I think in a sort of step down approach, they're working quite well. There is, because of the way that it was originally contracted, we've got more than one contractual arrangement, and therefore some of the pathways are slightly different. So I would like to see some of the clinical pathways unified for the virtual wards. We've got 2 separate atrial fibrillation pathways, for example. So we do need to, I think, to work out how we do that. I think the challenge, and of course it partly speaks to how we interact with the rollout of neighbourhood health, is how can we now use virtual wards in a step up way, in other words, to bridge from the community to an area which avoids a hospital admission, as opposed to shortening a hospital admission or somebody who's seen in the hospital or SDEC or something.
Very good. Thank you, Helen.
Yeah, I mean, on that, I think it's really the 10-year plan coming down the line where we know things will be moved out in, but it is really crucial that we're doing this, and it's a step to something new rather than just, oh, shall we or shan't we? So I think this is very important. We're going to be looking at it at our next quality meeting. So that was one. I think the other bit, just on clinical pathways, they are really, and they're really important from a quality and a collaboration perspective. They're not efficiency. They're not drivers to efficiency. I think we should accept that, because I think the collaboration aspect of them is hugely important.
So I completely agree with both of those points. I guess so I think definitely need to be working out what the opportunities are around things like virtual. I think it is very, very, we talked about earlier about the risks associated with removing 50% of the staff from the ICB. So there is a question about how are we actually going to implement neighbourhood health across North West London, given where ICBs are heading to just be strategic commissions. So I think we need to make sure that we're not caught napping and that we do have a proper forward-looking plan. I agree with you about the pathways. Interestingly, quite a lot of them will lead to efficiency. They're not large-scale efficiencies, but they will drive efficiencies.
Benita.
Clinical pathways again. Good to hear that they're going to come, but plan to embed the reporting on either quality improvements or efficiencies or whatever else arises in any of the governance structures that we.
Yes, so so each of the pathways has a set of metrics by which we will judge success or failure, and that will come through the APC-EMB on a monthly basis.
And is there a summary of that comes at any point?
The summary will then go up to the quality, because as Helen said, it's primarily a quality initiative. It will go up to the board in common quality, and then from quality to here.
Very good. Thank you. Thank you for that. Good. Let me move on now to the reports from the chief executives and the standing committee. So if we can do London North West first, and Pippa, I think you're going to report from the standing committee as well.
Thank you. So I'll just pick out three things from my report. It seems really old when it's coming here. I think just the important thing of the staff engagement events we've got running at the moment, they're normal engagement events we've got a lot of staff attending them, somewhere between 600 and 900 staff every time we do an event. The whole change in the NHS, the news, the media has caused a lot of unrest, and the headcount reduction, all of that is causing a lot of uncertainty to staff, particularly our lower banded staff actually, and some of it around our international staff that didn't understand. They think the NHS is closing and all of that. So it's been really important. We've got very close engagement and very good engagement from staff, so we can communicate with them. The other point I'd pull out is before all of this operation plan, actually, we spent some time as an executive team agreeing what our 4 priorities for the trust were for this year. And we've sort of really embedded them all the way down through people's appraisals. But they are to deliver a reduced amount of care to patients in temporary escalation spaces. That's been a real challenge for us this year, and we're very committed to looking at different models so we don't have to do that.
Fewer people in temporary escalation, less care to the people who are in.
Yes, and fewer people in less temporary escalation spaces. Improve our referral to treatment targets, and James has alluded to them. So where we've set in the operational plan a 60% compliance that we're aiming to achieve. We've got more work to do, and we're really pleased with our progress around staff engagement, culture and our equity work. We've delivered some great work this year, but that won't stop there, and we need to do more and continue that work. And our last priority is, of course, to live within our means and deliver our sustainability plan. So there are 4 priorities. They just happen to actually link with everything that came out in the operating plan, which is helpful. The last thing I would say is just the point of research. So we've been very successful this year. We're now one of only 3 trusts in London that have been designated as a commercial research centre. We got £7 million this year to invest into that, and we're looking to build in 40 trials. We've done some really impressive work. Actually, Christiana, who leads this for us, is doing some great work around the populations that are within our local population, around the equity and access to research as well. So it's caused quite a lot of interest nationally and by some very big So that's really important work that we're now delivering, and we've had great engagement with clinicians across all specialities actually want to be part of this. So that's really positive. And you'll see some lots of recognition of staff actually. The one I will call out, just because they so rarely get a mention, is our cybersecurity team. So one member of our cybersecurity team, I have to say, if anyone wants to know about cybersecurity, go and talk to Nazo. He can make it sound very interesting. But he rightly so did win 2 awards. So the diversity in cybersecurity, and he was awarded by NHS England Cyber Associates, which is really positive. Great work from him.
Right, thank you. And do you want to
Standing committee, very much like you would have expected us to discuss a lot about the financial plan and the operating plan. Big discussion around quality and the equity assessments that will be completed within that. So we can ensure we deliver that quality and improved quality while also delivering an operational and financially challenged plan. Huge conversation around our staff survey, which was really positive for this organisation. Again, a second year, actually the most improved staff survey in London, which is great. Again, not resting on our laurels there and more to do, but really starting to change direction of travel for the staff survey. The biggest conversation, the biggest challenge was obviously around how we now deliver the workforce reduction and change our services to live within our means and deliver the financial plan. That's largely what we covered in the meeting.
Right, thank you. Any questions for Pippa? Nita?
It's not specific to London North West, but since you've mentioned equity a few times, the recent Supreme Court ruling that provides clarity.
Yes.
Maybe how is that impacting?
Yeah, so it's obviously caused unrest with our communities within our workforce and our patients, which we have a large proportion of patients within North West London and staff actually that this would be impacted by. So it is obviously caused unrest. I think what we've done is sent out internal staff comms to give reassurance that we respect and support all staff in an equitable way, and that will not change. We are now waiting for the NHS England are working through what that guidance actually means for health. And that's what we need to wait for. We will be doing nothing more until we get the guidance from NHS England around how that will change health. It may potentially change some things like single-sex accommodation and things, but we will be doing nothing until we get the firm guidance, and that is being worked through at the moment. So at the moment, it's keeping the calms, the supporting staff, the supporting patients. It's really good.
Thank you. Excellent. And move on. Let me take Leslie next. As said earlier, all the chief executives have to rush off to a meeting with the NHS chief executive, but Leslie's actually presenting on it, so it's going to leave, I think, after she's done this report.
Thank you very much. That's really kind. So if I take Hillingdon first, if that's all right, Chairman. A big thank you to the Hillingdon team, and Alan can add whatever he would like to add. You can see we've articulated as all the changes at the executive level to make it very clear about who's there, who's doing what. And I would say that team is settling down really well together. We've got some challenges. So I said earlier that I think that we're waiting for the CQC final report to come in, and we will certainly report on that. But let me just say that the organisation has completely accepted and embraced the fact of an approach to seeing the CQC report and the commentary as an improvement methodology, and understanding that actually it's helpful being articulated where efforts need to be targeted. The area in terms of performance that we're really thinking about is, so you can see that in RTT and in many other areas, Hillingdon does really well. We've got quite a lot of work to do around our emergency performance, particularly our type 1 performance. Alan's doing a lot of work around that. We've got ESIST, I was going to say cousins actually, but ESIST colleagues coming in to have a look and work with our clinicians around that. So ESIST is the improvement arm of England around emergency care. I hope you can see in here that some amazingly good things that are happening there, certainly around the inclusivity work with the networks, but a really impressive piece of work by our breast surgeons working with the Royal Free, which you'll see, and I think it's on TV this weekend, isn't it? So that is really good. We've also, you sort of can understand the context. We've got some work to do around the staff survey and what the staff survey tells us, but you will often see when an organisation is under pressure and has the external commentary, sometimes that impacts staff survey, and I think we're accepting of that. And again, we will work together. Happy to take any questions about that, and then Caroline might want to say about the standing committee.
Any questions for Leslie? No, anything from the standing committee?
I don't have anything. I think Leslie's covered all the items already, so I don't really have anything to add. Just to say though that we did have, I thought, a really good, development session in advance of the standing committee, and I don't know whether everybody else is doing this, but I would recommend it because it did allow for a really more thorough and free-flowing conversation. So
read into that challenging.
Everybody did agree with Leslie at all points.
It's good for you, Leslie.
That was
very good. Thank you very much. So, Leslie, Chelsea.
Chelsea, again, of course, some of these executive plans have impacted on Chel West as well. And a big thank you to the exec team there who have come for some new roles and some new ways of working, which has been really, really helpful as well. You can see quite a lot of this, again, the work around research and innovation, and indeed the sort of work that we've been doing around recognition and celebrating success. If you don't know who Cormac Milcreast is by now, he's the most famous person in our whole organisation. You need to go and meet him. He lightens every day, is all I can say. He's a volunteer there, and he's a really interesting. He's a national hero, really. But so he's worth meeting. But again, quite a lot of work to do around the financial challenges. Quite a lot of work to do in terms of keeping performance where it needs to be. And we've been doing a lot of work actually at both trusts around infection control and around smoking, because we're expecting the smoking announcement around hospitals to come out pretty soon as well. Other than that, it's all the rest of the stuff that everybody talks about.
Thank you. Pat, anything from the standing committee?
I mean, I think the only thing to add to it is we did discuss quite in detail about the people survey that came out. One of the good results for Chelsea and Westminster, but also some of the challenging areas about some internal bullying and harassment, and also about the action plans being done by the trust. And we looked at the inquest. Roger updated us on that, and I think it was a good.
Thank you. Any questions for Leslie or Pat? Okay, thank you very much. Thank you, Leslie.
Thank you.
And Tim.
Thanks, Matthew. I think a lot of what I've got here is we've talked about previously, just to highlight a couple of things. So the changes that we've made to the maternity self-referrals at Queen Charlotte's have started to see some impact in terms of bookings. We haven't yet seen the impact in terms of reduced demand at the other end. I'm quite keen to see what happens there, because one of the big things I want to get out of this is us turning down fewer referrals of high-risk pregnancies from North West London patients. So we will hopefully that will work its way through. Pleasing response to the staff survey. There are nearly 10,000, with 9,994 people filled in the trust survey. If I can find the 6 people who did almost 10,000 voices. Yes, I absolutely did. And again, we had a very, very good staff survey last year, so we were not anticipating doing quite so well in given the circumstances this year, but actually pleasingly made further improvements this year, including in staff engagement, and morale particularly. And we actually do very well benchmarking at Shelford, which is always pleasing to see. We have announced, as you will have seen, Stanton Williams as the architect for the Fleming Centre, which is going to be built at St Mary's and will be an institute for antimicrobial resistance research. And Lord Darcy has done an amazing job of spearheading the fundraising for that. I think we've discussed all of the performance issues. I do want to highlight violence and aggression because this is an issue I think that we are seeing a lot of, and I've been sharing the group on trying to combat that. We now see on a weekly basis at the executive all of the violence and aggression incidents, and it's very interesting because we've done a lot to try and work how we can sort out the environment to make it less conducive to violence and aggression. We've been training people on how to de-escalate situations, and we've been really trying to focus on then how we give people immediate support after them. One of the interesting things we are seeing, however, is a lot of these incidents are not, just horrible people coming in and being terrible, nor in fact necessarily intoxicated or on drugs. A lot of it is to do with that underlying clinical conditions, which are either things like dementia or physical illness or mental health problems. And I think it's particularly important, it slightly goes to Simon's point about discharge. A lot of the patients that we are now finding it very difficult to discharge are patients who don't have an acute medical problem, but do have really complex nursing and care issues that mean that they are very problematic to keep on an acute. And so, and that is having an impact on the staff, particularly when we're so busy that we're outlying. And so we are really trying to look carefully at how we can tackle that particular issue, because I think it is becoming a significant issue, and I think we will have to try and be as inventive as we can do. But it highlights, if you are not looking after patients in the right environment, in a sort of calming, quiet environment, then you precipitate these incidents. So I just sort of flagged that. And then finally, just a couple of other things. Research and innovation, nearly 40,000 participants into NIHR portfolio studies this year, which I think we're very pleased with. We've just started the mid-term review of our biomedical research centre. It's got some interesting BRC funded projects there. The AI model that can flag to female patients who are at high risk of heart disease. It's an interesting one. And you can see AI now being used in chest X-ray reporting. And particularly pleasing from a recognising success perspective to see 3 nurses, Duncan Barton, the Chief Nursing Officer, came to give 3 nurses gold awards in February. Caris Barton, who is our spectacularly successful heart failure nurse, Mary Darwood, who has been an amazing stalwart in the emergency department, Sylvia Turner, who's one of our rapid diagnostic service practitioners. Finally, green, really good. We've got all of our horrible old lights being replaced, 30,000 light fittings being replaced with LEDs thanks to a grant, decarbonisation grant, which is very good news. People who know our hospitals, lighting is miserable. So actually, I think it will make such a difference to the environment, and it'll be a lot cheaper. Exactly. So all of that is very good. And the final thing is, can I just reiterate the chair's comments about Claire Hook, who when does she go?
It's just gone off picture. No, she's gone.
So I first worked with Claire, I think, 2013, when she came to be the Divisional Director of Operations in medicine, and I'd just been appointed as Divisional Director for medicine.
Yes.
She survived 12 years of working with me. So anything that the prick can throw at her, he has nothing. So I think we said in the paper, I think if we think about where the organisation was 12 years ago, we had massive deficits. We had 10% CIP asks. We had terrible issues with quality, with weight, and Claire has been instrumental in helping us really make considerable improvements, both in terms of finance and operational performance. And she has a notably calm and unflappable demeanour, which cannot be said for the Chief Executive. So we are really sorry that she is going, but very grateful for everything she has done.
Very good, thank you, Tim. Bob?
Again, hope the report's self-explanatory, and as with others, given the timing, spend a bit of time assured about the 4-5 financial position and feeling more comfortable with the underpinnings of the 5-6 plan. But there are three things I would bring out because I thought it was important that the steering committee covered this in the context of some personnel changes around the table and people needed to be exposed to things, I think. So firstly was the work of Imperial Strategic Lay Forum. It's been quite important for the executive, but I think some people around a wider table would not just have understood just how ingrained it was in some of the work. So I think that was a useful piece. And we need to make more of that. We need to be more visible about it. I'm not saying we do more of it, but we need to be more visible about it. But it was a good set. Secondly, some deeper exposure about the state risk around St Mary's and Charing Cross sites and the mitigations that are being attempted to put in place to prevent significant estate failure, but more to do. And so steering committee wanted to see more of that. And then finally, the start of a conversation on risk appetite. That was a good starter, but we need to come back to that later in the year after certain things have landed. It needs to go around another iteration. Then we'll do that again, Tina, in the next slide. Yeah, that'll do.
Thank you. Thank you. Any questions for Tim or Bob? Let's start with Adrian.
Oh, right, Nick. Yeah, no, it was just a general comment about all 4 reports for the trust, and it was about the staff survey results, and it's a generally positive picture, and I accept it, and the response rates are better as well, etc. But just a word of caution, I think that in terms of the acute average, the APC scored consistently low thematically across. We work flexibly, we are compassionate and inclusive, and we are recognised and rewarded. I think those are the 3 areas. I would just say that there's quite a lot of work to be done in these areas. And I think just to pick up on your point, which is about advance and aggression, which is specifically an area under the inclusive.
Yeah, so I don't think any of us is complacent about the staff survey. You know, I mean, we've seen a very big increase in the proportion of people who are saying that it's a fair place to work. And I'm delighted about that, but it's taken us from 48% 2 years ago, 52% to 55%. You know, so we're still only just about 50%. You know, I'm delighted that there's an 8% difference, but none of us, I think, are in any way complacent about that. We know that the scores in London tend to be lower than they are around some of the other parts of the country. I think it is good that we are getting more people responding, because then we can have more confidence in what they're telling us. And of course, the other thing is we need to go through the free text, because the free text is very, very important about people's lived experience. So I think we would all recognise that there's an awful lot we need to do. The issue about working flexibly is going to be a one and quite a tricky one, because I think there is something about saying that the healthcare that we provide is geographically based. People need to be on site to provide that. And if you have a management team that is completely away from that, that's a difficult thing. And so I think we will, over the course of the next year to 2 years, I think some of that may play out in the staff survey until we get back to an equilibrium about what roles need to be where.
Yeah.
Well, I was just going to say as well, it needs to be now played alongside our res reports. We've all got our res reports. We're just starting to just analyse the data, and it will come through the committees. But that gives us more direction in terms of where we do need to be working harder to be inclusive organisations. So that's an important document that goes with the staff survey as
well. Thank you, Vinita.
Excellent report. A lot of good work at Imperial. Sorry to on one area that did concern me, which was the pausing of the neuro-oncology surgical services. Give us a bit more detail on that, and was there any serious incident behind that?
Yeah, so as I mentioned actually earlier in the report, so we restarted the service after 2 weeks as we had expected to, keeping a close eye on it. The The MDT appears to be working, I think, well. We are reviewing all of the cases that we'd sent out to the Royal College of Surgeons. We are going into some of those in detail. But I think the medical directors are now confident that that we have a safe service, and there was never anything that flagged. We had an episode at the beginning of 2024 where we had a higher incidence of surgical site infections in cranial neurosurgery. That was short-lived, and mitigations were put in place, and that then settled down. There's nothing else in the sort of outcomes that you would look at and say there's a big problem here. So I think we are confident that that what we're doing now is providing an appropriate high quality service. But having said that, the medical director's office are very actively involved in monitoring that to make sure that that stays the same.
Thank you very much.
It's been just to add to what Tim said and offer further assurance. We are, as Tim says, we're giving you an awful, and very specifically, there is no individual failure here. This is about the whole team, the wider team working together. So, as you will appreciate, it's a very complex service for North West London and for London, and the way that those teams have come together over time hasn't been quite right. So there's a particular focus on neuro-oncology, but also the whole neurosurgery, an awful lot of support from the MDO, but the trust more broadly, and in fact NHSE.
Very good. Thank you very much. Okay, I'm going to move us on to the Trust Zoo. Use of the Trust seal.
I'm not sure what to respond to that. It's been a long meeting. So this is an annual report for noting, actually, so I don't want to go through the detail. Is required under our standing orders that we report on the use of the trust seal over the year. So
it's literally a wax seal.
It's not wax anymore. Well,
not
a wasted money for you.
The London North West bought 200 years worth of wax back. Okay, that is for 13. I don't have any other businesses alerted to me, but days. Oh, which place? I can close the formal part of the meeting. Open up to questions from members of the public. We've not had any, I don't think, submitted in writing this month. So I would invite people to raise their hands either in the room or on screen. Please, sir.
Trevor Arnold, Portisburg, Siemens Health and Ears. My brief question is regarding the new hospital programme. Government reprioritised the schemes in January, once again resulting in frustrating delay imperial schemes. There's been talk from various quarters about a potential new and needed approach to PFI, and more recently from Sir Jim, resurrecting support for special purpose vehicles. My question is, how has all of this influenced Imperial's thinking about how to move forward with these much needed gains?
Thank you. Tim, do you want that or do you want to throw it?
Yes, so good question. So we spent quite a lot of time initially having conversations with both Department of Health and we have secured some funding for this year to continue with our planning for the St Mary's campus, sorted the most significant problem for us. We've also set up a task force we are launching with West to explore how we can most effectively use the St Mary's campus, and we're actually also working Fulham, working relationship with to think about how all of this fits in the general what I think used to be called the Imperial West Tech Corridor, but they're about to change the name, which is essentially all of the biosciences campuses from South Kensington out through to White. And so we're sort of looking at that as a driver, because I think that there is an argument here that says not only will this be a healthcare asset, but it will also actually be a life sciences and growth potentially asset for, and that's an argument to put to the government. You're quite right that Jim Mackey, I think, is very keen to explore new ways of these sorts of developments, because there are a lot of old hospitals. And funnily enough, I'm surprised to hear that happen.
Thank you.
Thank you. Robin.
Thank you, Chair. Could I say, first of all, profound thanks to all providers for, the terrific works being done in difficult circumstances. So my question goes really back to what you said very early on, that the business plan is based on the idea there will be no growth in demand. Demand will be flat. And I wonder how safe an assumption that is, given recent history. What are the serious projections about demand? I thought there was to be growth. So that links really to the figure of 1,260 staff equivalents to be lost. I didn't hear the word cuts mentioned, but to me that means cuts. And doesn't it mean cuts in patient care if these are clinical staff? I have a separate question for someone who was in the meeting. We had to leave early, but that's my question. Thank you.
You have first question.
So Robin, obviously Tim alluded earlier, we have to all acknowledge that that is one of the risks, that we have made these plans assuming that our activity levels will remain the same. However, we are all part of Acute Trust, of working with our landscape across North West London to initiate the health neighbourhood teams, and we are part of initiating them as well. So that we're not just sitting here waiting for the solution, we are actively engaging with the solution. In terms of the headcount reduction, you'd have seen in them numbers that actually what it's asking us to do is live back within our means. So the big proportion of reduction is because we overspent on our funded establishment last year. We have to go back into a funded establishment. On top of that, it's actually only a 1% reduction on top of the funded establishment. So it's quite small. We just need to live within our means. And that's what we didn't do last year. And that's what we'll be aiming to do this year.
Jim, do you want to add to that?
Yeah, not very much, actually. I mean, I think it's a good question, Robin. I think, how realistic it is that there'll be no growth, I think is difficult to say at this stage. It does depend on how effectively we can work with the ICB to help deliver the left shift. I think that's absolutely true. But to Pippa's point, I think it is important to remember that the big thing we've been asked to do is to remove half of the growth in non-patient facing staff since 2018-19. So we have added quite a lot of staff, and I think it's not entirely inappropriate to go back and say, actually, have we got the right structures across our organisations to deliver for patients? I think that we, as people said, the funded establishment has been calculated on the basis of the patients that we think should come through. So there is a little bit about, we can do a lot of this by really focusing on making sure that we've got our rostering sorted out, that we're managing our leave, probably a whole range of what you might call sort of good hygiene, good management hygiene.
Thank you. Thank you. Armel.
Yes, good afternoon. I wanted to say the same as Robin, actually. I know you're working very, very hard behind the scene and also in very difficult circumstances. So I want to thank you all. I live in Harmondsworth, which is part of London Borough of Hillingdon. And I just wanted to ask what positive improvements in patient care can be highlighted since Leslie has taken over in January 25. And following that question is, we don't have any members newsletter. We've only had 2 in the last, well, just before the members meeting last year, and then just before Christmas. And I get a newsletter every month from Chelsea and Westminster. So if we got more news, then we would be kept updated, especially as I'm the founder member of Hillingdon Foundation Trust. Thank you.
Thank you. Alan, can I turn to you for that?
Yeah, thanks, Arnell. Leslie's had to step out of the meeting, but I'm the Chief Medical Officer, as you know, but also the Managing Director now. So I'll take that last point about the newsletter, making sure that it's more frequent. I'll take that back to our communications team, who are upgrading all of the services that they're offering. In regards to the changes since Leslie has come in, we're focusing a great deal on our most urgent problems, which are emergency care and maternity care, and also making sure that we're going to balance our books. I'm very pleased to say that there's a great deal of continued sustained improvement in maternity and paediatric services, particularly stillbirths and babies that are born outside of labour ward. In regards to emergency department, we've noticed over the last 3 months, month-on-month improvement on the most important cases, are type 1 cases. So over that last 3-month period, I think we're up 6% from where we were just before Christmas. But these things take a long time before you get sustained improvement, in my experience.
Thank you. Thank you very much.
Thank you.
Hello, is that my second question?
I think we're on for your second question.
Yes, thank you. Thank you. It's on behalf of Gaynor Lloyd, who, apart from many other things, is the only lay member of the ICB Info Governance Committee. And she has a question on page 189 of the papers about the EOC. And there's reference to problems with both Cerner and the Federated Data Platform in allowing patients to access smoothly to the EOC services. And her question is, have the problems mentioned in the papers been resolved, please? Thank you.
Thanks, Robin, and thanks again, because she gives us a lot of support with our digital pathways and feedback, which is helpful. So there's 2 elements of the data piece for the EOC. One is how we transfer patients and manage patients through the system. That's done through the Federated Data Platform. That is now resolved, and more flexibility in the way that we can design the Federated Data Platform, and we have been able to iterate that, and that now works quite smoothly. The second one is around access for clinicians to work across Cerner platforms. That is a resolving issue. It's not fully resolved yet. So at the moment, what happens is they can read patient records across all of our sites. What they can't do is request tests and things like that if they're not working on the site where the patient is. And that's a piece of work that we're just doing now across the APC. It does allow some issues around data security, but once we've got through that, we'll be able to resolve that as well. So that will be a resolved issue.
Excellent.
Thank you.
Well, thank you for those questions. And if any others, I am going to close the meeting. So thank you for joining us. Thank you to members of the public who took time out of their days, and thank you very much to the board for their time. And have a good afternoon. Thank you.